Welcome you to the fourth webinar in Arthritis and Osteoporosis Victoria's 2016 Musculoskeletal Health Webinar Series. Tonight's webinar will examine the surgical management of the arthritic knee. Before introducing our presenter for this evening, however, I have just a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the organiser at Redback Conferencing. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will generally answer questions at the end of his presentation, you can actually type questions for him at any time, and he will decide as he proceeds through his presentation whether he'll deal with the question at the time or deal with most of the questions at the end of the presentation. We suggest you don't leave your questions to the last minute, as we will aim to finish strictly at 8 p.m. Australian Eastern Standard Time. I'd also be very grateful if participants could take a moment at the end of the webinar to answer our exit survey, which is always very helpful to receive that feedback. It will only take you about 30 seconds to complete. Our presenter for tonight is Professor Ian Harris. Ian is an orthopaedic clinician and academic. He is Professor of Orthopaedic Surgery at the University of New South Wales, but his clinical work and research activities are based at Liverpool, where he directs orthopaedic activities for South West Sydney and heads the Whitlam Orthopaedic Research Institute. His research is clinical in nature, and he has an interest in surgical outcomes and evidence-based medicine. He is also author of the book Surgery, the Ultimate Placebo, which questions the scientific basis for many surgical procedures. Without further ado, I'll hand proceedings over to you, Ian. Thanks very much, Ian.
Okay, and thanks very much for inviting me. So, as you've heard, I'm Ian Harris. I'm an orthopaedic surgeon and a researcher, and I'm going to cover the topic of surgery for the arthritic knee. We're going to cover a little bit about the epidemiology, the burden of disease. I'm not going to cover too much, and we're going to look at causes, and then we're going to go through each of the operations that we can do one by one. The burden of disease I don't need to talk about too much. We all know the widespread nature of osteoarthritis, particularly osteoarthritis of the knee, particularly osteoarthritis of weight-bearing joints, so that's the hip and the knee. But knee is by far the most common. For us as practicing orthopedic surgeons, this is the bread and butter patient. I wouldn't have a consulting session without seeing several patients with degenerative changes of the knee at varying stages with varying symptoms. So it's a fairly huge burden of disease. It's very common. The epidemiology, we're going to look at really who gets it. I'm going to get into that in a minute, and we're going to look at the causes of it. So going on to the next slide, the causes can be summarized as wear. That's what osteoarthritis is. Osteoarthritis is a loss of the cushioning chondral surface of a joint. And there's lots of things, though, that can make it wear. So there is, to some degree, an age-related phenomenon where osteoarthritis is much more common in older patients. But there's other things that can also make that wear happen faster. Any increased load, just like any piece of machinery, will make it wear faster. So obesity, for example. Other things that may increase the load is deformity. So if somebody has a varus or valgus knee, so that the knee is not symmetrical and well balanced, it will throw an increased load on one part of the knee, and this will increase the wear rate on that part of the knee, and you'll see some pictures of this shortly. A loss of padding can also increase the load and increase the wear rate. And the meniscus is a very important component of the knee that helps distribute the load evenly. When you lose your meniscus, you have increased load over a smaller area, and this increases your risk of osteoarthritis. If the joint surface is not smooth, you will get osteoarthritis, and this commonly occurs after fractures where there is residual deformity, particularly any steps or gaps in the articular surface. And instability is the final thing, and this is typically something like a cruciate ligament tear, where the knee does not move smoothly anymore, and it moves into abnormal positions occasionally, and this also causes increased load, and the increased load causes wear. So there's lots of causes of osteoarthritis. If you wanted to break that down, you'd probably break it down into generalized age-related changes and specific sort of causes other than that, and often that's post-traumatic. It's loss of a meniscus, it's an old fracture, it's a ligament tear. Any disruption in the knee can increase your risk of osteoarthritis. So we've got the causes, and there's a classic picture of osteoarthritis, and this is when the patients come to you and they say, oh, I've got bone on bone. That's actually a pretty accurate representation. So when you look at that, there's a good joint space here on the lateral side, but on the medial side, but when you look at the lateral side, there is no cushioning. And patients often don't understand this. They see a joint space. They don't understand that there is actually no space in the joint. That space is filled with cartilage. And when that cartilage disappears, the bone at the top contacts the bone at the bottom, and this is what you're looking at here. Now this is unusual because this is lateral only. And so I suspect that this patient has had a lateral meniscectomy, possibly 15 or 20 years ago. So now looking at the types of knee osteoarthritis, we normally divide it into where it occurs, and just some pictures on what that looks like. This is typical medial compartment osteoarthritis, where you can see narrowing of the joint space of the medial compartment with good preservation of the joint space in the lateral compartment. This is a skyline view of the patella, and you can see there that there's no cartilage left between the patella and the trochlea, bone on bone, end-stage osteoarthritis. And it can be isolated to the patellofemoral joint. Again, after trauma, malalignment, increased loading, all of the same things that can cause osteoarthritis in the other compartments can cause it in the patellofemoral joint. And it can be just multi-compartmental, where you can have narrowing of the medial side, narrowing of the lateral side, and even narrowing of the patellofemoral joint. So that's the way we normally describe it. By far the most common one is medial compartment. So what is the average patient? What's the average patient look like when they present to you? Most of them are older. So you can have patients in their 30s and 40s with osteoarthritis, but by and large it's patients over 50. Increasing age, increasing prevalence of osteoarthritis. They'll often complain of knee pain with loading. So it's when they walk a certain distance, when they go up and down stairs. It's when they load the knee, and often they don't have that much pain at rest. They will normally complain of stiffness. Stiffness is not loss of range of motion. Stiffness is difficulty moving the joint. And the typical arthritic patient will describe difficulty getting the knee moving after they've been sitting for a long time, such as sitting in a car or sitting at a cinema. They'll say they have to take a few steps to oil the knee before they can move freely. That's a very common symptom. Most patients, when questioned, will describe all sorts of mechanical symptoms. The usefulness of this symptom is questioned, but often they'll complain of creaking, grating, locking, catching, clicking, and typically it will have acute exacerbations. So a patient with osteoarthritis, is very rare for them to have the same pain day in, day out. They will have flare-ups of severe pain. They'll have times, maybe many months, when they're coping very well, only to have more exacerbations down the track. The investigations, plain radiographs are the mainstay of investigating osteoarthritis of the knee. If you have patients with knee pain over the age of 50, they need a plain radiograph, and that's just about it. It's very common in some areas to get an ultrasound of the knee. An ultrasound of the knee is not a good test. It does not show you degenerative changes. It does not show you the meniscus well. It nearly always shows you a Baker cyst, and which is of questionable relevance, and it's really not used. CT scans also not very useful because they show you very good detail of the bone, but not of the soft tissues or the cartilage. MRI scans are really not useful for osteoarthritis of the knee. If you have it on a plain radiograph, that's all you need. And this is a bit of a bone of contention lately, because many orthopaedic surgeons are now seeing patients with MRI scans but with no plain x-rays, and having to send them just to get plain radiographs, because that's how the planning of surgery is done, and that is how we rate the severity of osteoarthritis. So if you want to look at the plain radiograph, this is a typical picture. Now, it needs to be a weight-bearing radiograph. This x-ray may look normal if the patient is lying down, and what will happen is the joints will drift back apart, and you'll see a big wide joint space here, and it's only when you get the patient to stand up that the bone comes down and touches the other bone again. So it has to be a weight-bearing x-ray to really judge the severity, certainly of the joint space narrowing. But the other features of osteoarthritis, you've got the osteophytes, this little outgrowth here. You've normally got subchondral sclerosis. I think that was shown better on the earlier x-rays. And you can get degenerative cysts in the bone around the joint. So quickly just covering non-operative treatment before we dive into the surgical aspects. These are some of the things you can do: weight loss, activity modification, physiotherapy, non-steroidal anti-inflammatory medication, and bracing was used for a while, but the evidence for bracing is not very good. In fact, the evidence for a lot of these things is really not very good, and they offer really a marginal benefit. If you look at the evidence for these, there was a Cochrane review on exercise for osteoarthritis of the knee, showed very little benefit, and the degree of benefit included the possibility that this was not of a significant extent that it was relevant to the patients. In other words, it did not include the minimum. It did include the minimum clinically important difference. So exercise, yeah, it probably has some benefit, but it's not a huge benefit. These are some treatments to avoid. These are all injections. Injection therapy for osteoarthritis is largely either ineffective or, at best, of temporary effectiveness of several weeks, perhaps stretching into months. And even then, the size of the benefit is very small. I do not recommend injection therapy of any type for osteoarthritis. The top one there is the common glucosamines, krill oil, shark cartilage, things that patients often take. The evidence for these is weak, and I do not recommend them. Stem cells, platelet-rich plasma, hyaluronic acid, corticosteroids, I do not recommend. A couple of those, just looking at them specifically. This is a Cochrane review of intra-articular corticosteroids for osteoarthritis, and it showed it had little or no effect, and what little effect it did have in some studies was very short-lived. There's also risks involved in using these drugs in the knee. There's an increased rate of infection, and large population-based studies from the United States recently have shown an increased risk of infection after total knee replacement in patients who have previously been treated with intra-articular corticosteroids. I do not recommend corticosteroids for osteoarthritis. This is viscose supplementation or hyaluronic acid. This particular review is interesting because there's been a lot of randomized controlled trials of hyaluronic acid, and this one teased out the high quality from the low quality studies. And what they found was that in patients with knee osteoarthritis, viscose supplementation is associated with a small and clinically irrelevant benefit and an increased risk for serious adverse events. And in fact, in the highest quality studies, they found almost no benefit over placebo. I do not recommend hyaluronic acid injections. Now we get into the crux of it, and these are our 4 surgical options. If you've got an osteoarthritic knee, it is possible to have any one of these: arthroscopy, arthrodesis, which is a fusion, osteotomy, and arthroplasty. And I'm going to cover each of these in turn. So starting first, these in turn. So starting first, sorry, there's a glitch there. I'm going to skip over that slide. So these are some of the studies looking at arthroscopy. And this study looked at, sorry, not arthroscopy, but this study is looking at the association between having a meniscus tear and being painful. And what this study found is this is a population-based study of roughly about 1,000 patients aged over 50, or between 50 and 90. And they took MRIs of all of them. Some of them had knee pain, some of them didn't have knee pain, and some of them had meniscus tears on their MRI, some of them did not. Now, most of those meniscus tears were degenerative in nature, which is by far the most common meniscus tear we see. And they found that in those patients with some degree of osteoarthritis on their X-ray, the presence of a meniscus tear was no higher in those with pain compared to patients who didn't have pain. In other words, pain is not a predictor of whether you've got a meniscus tear or not. And in fact, most patients who had a proven meniscus tear on MRI did not have knee pain. Meniscus tears on MRI are exceedingly common and they are not associated with pain. So this is the sort of setup for the treatment. So this means that the treatment to address the meniscus is probably unlikely to be effective, and that's certainly what we found. And that should be OA, not AO. So the association between osteoarthritis and knee pain, there is some association, but half of all patients with radiographic knee OA will have pain. So just because you've got knee OA on an X-ray doesn't mean you'll have pain. In those with pain, there is a very poor correlation, though, between severity and symptoms. So we can see patients who have end-stage osteoarthritis on an X-ray but don't complain of much pain, and we can see patients complaining of severe pain with only mild osteoarthritis. So this makes it very difficult for us as surgeons in our decision-making. So let's get on with the arthroscopy versus non-operative treatment. And this is a study from 2008 comparing it to a structured exercise program. And in 188 patients with knee osteoarthritis, they compared arthroscopic surgery to exercises, and they found no difference. And if you look at this, the two groups plotted there is arthroscopy and the control exercise group. No difference at any time point between any of them, except maybe the first few weeks. Another study here, this one looked at over 100 middle-aged patients with osteoarthritis and mechanical symptoms and a medial meniscus tear. And they looked again at exercises with or without an arthroscopy. Again, very little difference. Possibly in the first few months there's a marginal difference. These differences, I should point out, are below the minimum clinically important difference. So if there is a small temporary effect of arthroscopy, it is not a clinically important effect. There's many more studies. Now this one again looked at patients with a meniscus tear and osteoarthritis. This is the largest study done. This was 351 patients, and again, age 45 and over, which is our typical patient with mechanical symptoms, meniscus tear and osteoarthritis. They had high crossover rates, but really they found very little difference between the two groups. A slight improvement early, but again, less than what is considered clinically important. And so that's the WOMAC physical function scale, and on the other side is the pain scale. Another study looking at arthroscopy or conservative exercise therapy for degenerative tears of the medial meniscus. This is about 100 patients, and again, no difference between the two groups. That's the arthroscopy group and the exercise group in any of the outcomes. Another study, this study concluding that arthroscopy was possibly beneficial. This is 150 patients, but without serious osteoarthritis, but with meniscal symptoms. Again, though, the difference was not large. and of questionable importance. Now, there have been some studies comparing arthroscopy to sham surgery. This was the first one. This was a bombshell study from 2002, which was a lead article in the New England Journal of Surgery. And they got 180 patients and compared them across 3 groups. They had sort of roughly 60 patients in each group, and they had one group which was sham surgery, where they just made incisions and pretended to do an arthroscopy. One is where they did an arthroscopy but just washed the knee out with no other procedure. And the other one was your typical procedure, which is a debridement of the knee, and that's what most people do for osteoarthritis when they do an arthroscopy. And this study was a very famous study because it really showed no difference at any time point, no significant difference with any of the groups. Interestingly, there was again a slight early advantage, and if you have a look here, you can see that there's a slight early advantage at the 2-week and 6-week mark, but the advantage was in the placebo group, which actually did a bit better than the other groups. And this was the most recent study and possibly the highest quality study that has been done looking at arthroscopy. This is a completely blinded, sham-controlled study of arthroscopic meniscectomy, which is the most common procedure done, compared to sham surgery, and patients were blinded. They tested blinding, and patients didn't know which group they were in at the end of the procedure. And the patients who had the arthroscopic meniscectomy, for patients with a proven meniscus tear, were no better than the patients who had the sham arthroscopy. Again, a slight benefit possibly in that early stage with no difference at 12 months, but that difference again is not clinically relevant or clinically important. And this was possibly the most famous study. They followed this up with another study from the same group, which was only published recently, looking at patients with mechanical symptoms. And they found that patients with mechanical symptoms who were treated with an arthroscopy were actually slightly more likely to have mechanical symptoms after the arthroscopy, and patients treated with the sham surgery were slightly less likely, although the difference was not statistically significant, but certainly no clear benefit from arthroscopy. So what do we have? The conclusion that I make from the studies on knee arthroscopy is that knee arthroscopy for any degenerative condition in the knee, whether it's osteoarthritis or a degenerative meniscus tear, or even for patellofemoral pathology, it is no better than any non-operative treatment that has been tried, and it's no better than pretending to do the arthroscopy. And yet it is still commonly used. So that leaves arthroscopy. Now we're on to arthrodesis. Now, an arthrodesis is a knee fusion. I mention this because it was once common and standard treatment for severe osteoarthritis. And in my junior medical days, it was not uncommon to see patients with fused knees. It was the ultimate trade-off. They would get complete pain relief from their osteoarthritis. However, they would have no movement afterwards. Very disabling, difficult to sit in a chair because your leg sticks out and you trip people over as they walk past. It's very difficult to walk. You walk with a limp. And these patients are significantly disabled from having a knee fusion. Today, it's certainly not readily accepted as a treatment for osteoarthritis. However, it is still performed, but it is largely reserved as a salvage procedure after a failed total knee replacement. So I won't mention anything else about arthrodesis except just to show you this picture, and this is what it is. We just turn the femur and the tibia into one bone. Very old-fashioned operation, and certainly not recommended for osteoarthritis now. So that leaves us 2 other operations. Firstly, osteotomy. An osteotomy is a realigning of the lower limb so that the weight-bearing load is redistributed so that it's thrown onto the uninvolved non-arthritic compartment of the knee. I've got some nice pictures which will explain that. So this is a typical opening wedge osteotomy, and the diagram on the right shows you what we've done. The knee is in varus, and so when the patient weight bears, the force goes from the ankle to the hip and falls down the medial side of the knee, causing a very great load on the medial side of the knee and a relative unloading of the lateral side of the knee. So when you see the x-ray, you'll see severe osteoarthritis sometimes on the medial side, but a normal-looking lateral side. By doing an opening wedge, you throw the foot back over here and correct that varus deformity, and in fact the principle of an osteotomy is to very slightly overcorrect the deformity. So the force doesn't go through the center of the knee. The force actually deliberately falls onto the good, unaffected lateral compartment, relieving the weight on the affected medial compartment. This is a very old-fashioned operation, but it is an operation that is certainly still done today. It's a reasonably effective operation for the right patient. And so there are criteria for who gets it. You need to have somebody who has osteoarthritis in one compartment only and where the other compartment is relatively untouched. Just got some more pictures to show you, and this is a typical one. So this patient has a very varus knee. It's a bowed knee. All of the weight is going on the inside. The joint space has gone, but the lateral side of the knee is relatively untouched. So if we throw the knee back over here, you can see now with weight bearing, we're putting more weight through here, and you're actually seeing a gap on the medial side. Now some patients think that this means that their cartilage has grown back again. It hasn't. It just means that this joint side is now being opened up because all the force is coming onto this side. So osteotomy, it's not a bad operation. This shows you the line of force between the hip and the ankle, and then on the other side. So what are the pros and cons of an osteotomy? It's joint preserving, and this is by and large the biggest advantage of doing it. You don't sacrifice too much by doing an osteotomy. It's all done outside the joint. So you haven't touched the inside of the joint. The risk of septic arthritis is low. You haven't damaged the lining of the joint, and it's largely that reason that it's often done. It does, because it doesn't affect the joint, it maintains your good range of motion. So if you have a patient with a very good range of motion, you'd be tempted to do an osteotomy because knee replacements normally give you a restricted range of motion. So it's again one of the big advantages. And the other pro, of course, of an osteotomy is that it works. It actually does relieve pain. There are some disadvantages. Possibly the biggest disadvantage of an osteotomy is the necessary overcorrection. And often these patients have, say, varus knees, and the varus deformity is often bilateral and symmetrical, and to them it's kind of normal, they're bow-legged. If you take one of their legs and you actually, to them it's kind of normal, they're bow-legged. If you take one of their legs and you actually deform it the other way, so that they're slightly knock-kneed, it can be quite ugly, and it can be, cosmetically very off-putting. And it's actually a common cause of lawsuits, is that if there's any significant deformity afterwards, perhaps from slight overcorrection, often it'll make a very disgruntled patient. The long-term results aren't that good. So we're deliberately putting more force on the lateral side of the knee, and what happens is eventually the lateral side of the knee wears out. But look, an osteotomy may be very good for 10 or 15 years in some patients, and this is why it's often chosen for younger patients. It's less reliable results than a total knee. With a total knee, you kind of know what you're getting. With an osteotomy, it may or may, the results are less predictable. But certainly in a younger patient with good range of motion and isolated osteoarthritis to one compartment, it's certainly a reasonable option. And there's maybe several hundred of osteotomies are done every year, so it's not that uncommon. But now this brings us to the big one, arthroplasty. Arthroplasty or joint replacement. A very common procedure. If you want to look at the numbers alone, there's over 40,000, possibly about 45,000 knee replacements, primary knee replacements done every year. And there's about 50 or 60,000 knee replacements if we count revisions as well. Australia has one of the highest rates of knee arthroscopy, knee arthroplasty. Other countries such as the US having the highest rates. Now, arthroplasty can be partial or total, and partial arthroplasty can be of the patellofemoral joint only, the medial compartment only, or the lateral compartment only. So these are the numbers. So we're pushing upwards of around 200 per 100,000 population every year gets a knee replacement. In America, that's about 1 million people a year. In Australia, knee replacement surgery comprises approximately 1% of the entire health budget of the country. It's a very resource-intensive procedure. Now let's look at the partial ones before we spend some time looking at the total knee replacements. If you look at patellofemoral joint replacement, this is the revision rate. So this data, when you see graphs that look like this is from our National Joint Replacement Registry here in Australia. And it has very good data on all of the joint replacements done in Australia. We currently have 100% coverage for this registry. So this shows you that after 10 years, the revision rate is somewhere between 25 and 30%. So that's fairly high. So patellofemoral only replacements, which of course are done for patellofemoral osteoarthritis, have a fairly high failure rate. And here's a picture just showing you how we reline the trochlea only. We leave the tibiofemoral joint alone, and then we resurface with a piece of plastic there the back of the patella. So it's just a patellofemoral replacement, but the results aren't that great. So let's look at medial compartment only, and again this is looking at the revision rate. And the revision rate at 10 years, if you draw a line up here, it's about 15%. So that's better than patellofemoral, but it's still not that great. And this is what it looks like. And it's really as advertised. We just replace one compartment. We leave the patellofemoral joint alone, we leave the lateral compartment alone, we just replace the lateral compartment. Now, why would we do this if the revision rate is higher? Well, it is a smaller operation. You can see the staples here on the x-ray show you that it's a fairly small incision, certainly compared to a total knee replacement. So it's less invasive. And again, it's sometimes done to buy time, and you can get a better range of motion after this than you can after a total knee. But as you can see, the results just aren't quite as good. Now, you can do the same operation for the lateral compartment as well. It's just that it's much less common to get lateral compartment only osteoarthritis, whereas medial compartment osteoarthritis really is the bread and butter presentation for us. It's what we see all the time. And now this is an interesting graph. This is again taken from the registry, and this shows you that over this roughly decade from 2003 to 2014, there has been a gradual decline in the rate of partial knee replacements from about over 15% down towards 5%. The yellow line is revisions, and so most knee replacements by far that are being done these days are total knee replacements. So even if a patient only has osteoarthritis in one compartment, most surgeons these days would tend to do a total knee replacement because the results are more reliable. So let's look at those results. And well, let's look at some pictures. And a knee replacement is different to a hip replacement. I have to explain this to patients because with a hip replacement, we do take out the entire ball. We take out a whole half of one of the joints and reline the other half. A knee replacement is really a resurfacing. I often describe it to my patients as a retread on a tire. Or new lino on your kitchen. It really just surfaces it. That's only a few mil thick. This is a little bit thicker in the joint here, but it's really just a relining. So the idea is to keep the shape and the contours of a normal knee replacement so that the ligaments remain balanced as they were before. Now, this is the same chart for a total knee replacement as I showed you for the partial knee replacements. And there's a dramatic difference. If you look at the 10-year revision rate, it's 5%. So for the top brands and the top types of knee replacements used, you should expect a revision rate at 10 years of less than 5%. And even at 15 years, we know now that it's only about 8 or 9%. So that means that over 90% of knee replacements will last more than 15 years. And this data is an overall data, and there's some argument that more recent data is even better. But it's not for everyone. So this is a graph that breaks up the revision rate by age. So if we divide patients into 4 blocks, those under 55, 55 to 64, the next decade, and then all patients over 75, we see a striking difference in the revision rate. Now remember that the average patient who has a knee replacement in Australia is a little over 65, so this is roughly dividing them into quarters. And you can see for the patient who is under 55, the revision rate at 10 years exceeds 10%, whereas patients over 75, it's about 2 or 3%. So younger patients tend to have higher revision rates. And this is possibly because they're more active. They put more demand on their knee, and therefore it loosens earlier or it wears out earlier. And there's more interesting discrepancies in the revision rate of knee replacements between male and female. Now this is a graph where each line for males, and over here for females, represents a cause for the revision. So for instance, the red line represents infection as a cause for revision. The green line represents loosening. And infection and loosening are the 2 most common causes of revision. Now these 2 graphs for men and women are virtually identical except for one difference. And the difference is that the infection rate is much higher for males than females. It's roughly twice. Now we don't exactly know why that is, but it's a consistent finding. It's been shown internationally in other registries and in our registry here that men have a higher infection rate. But you're still looking at roughly a 1% infection rate. And as you would expect, the revision rate for loosening increases as time goes on. And this is why the revision rate gradually increases over time. Whereas most of the infections occur early, loosening occurs late. So what are the early complications of knee replacement? What are the things we should look out for? The big 3 are infection, VTE, and stiffness. Now infection is possibly the most worrying of these, and there is a lot of variation in how we diagnose infection, and some people think that it's overdiagnosed, sometimes it's underdiagnosed. And unfortunately, we still get cases today where patients are missed or neglected, or they're in rehab, or they're in the community, and they have an infection which is not really detected until it's too late. And the other side of the coin is we have patients who perhaps have some redness around their sutures, which is very common, who are diagnosed with an infection and treated with antibiotics, possibly unnecessarily. So the true infection rate is very difficult to determine. The way we measure it normally is by looking at the serious infection rate, so the infections that require further surgery, the infections that require revision or a washout of the knee or admission to hospital for intravenous antibiotics. And that rate is roughly about 1%. VTE is much less common than it used to be. In the early days of joint replacement, it was not uncommon to have pulmonary emboli, several percent, and there was 0.5 to 1% of people would die from pulmonary emboli. It's much less common now. This is possibly due to several factors. Certainly most patients would have some form of prophylaxis for venous thromboembolism, but also patients are being mobilized much sooner. In the early days, they were kept in bed, sometimes kept in bandages or a plaster, and sometimes told to non-weight bear. These days, we try to get patients up on the day of surgery or the day after surgery, and we get them fully weight-bearing straight away. This early discharge, early mobility, and prophylaxis has dramatically lowered the rate of DVT and pulmonary embolus. Stiffness is a big problem with knee replacements. We don't see it so much with hips, but we see it with knees. And it's not uncommon for patients to have difficulty bending their knee after a knee replacement. And if this is a significant problem, an operation or a procedure is performed where we readmit the patient to hospital and bend their knee under anaesthetic, a so-called MUA, or manipulation under anaesthesia. This is not uncommonly done, certainly a few percent of cases. And with some effectiveness. But for most patients with a knee replacement, even a good result, they don't get a whole lot past 90 degrees. A good result, 100, 110, sometimes even 120, but they can't squat. This is not a big problem for Australian populations, but it is a problem for some Asian populations when they squat to go to the toilet. And there's a lot of work being done in trying to develop knees that have greater flexion. So that's the early complications. Now, the patient-reported outcomes, to me, are arguably more important than the revision rate. You can have a patient who does not have a revised knee, but still has a bad result. So the patient-reported outcomes that we normally look at, after a knee replacement are joint-specific scores. So there's things like a Oxford knee score or a Hospital for Special Surgery knee score or a knee outcome scale. These are joint-specific scores that give you some measure of pain and function within that joint. We also measure general quality of life. We measure complications from the patients, and most patient-reported outcome surveys will include some question on satisfaction, an overall score of how much they think they're better after the operation. Now, I direct a registry that collects patient-reported outcomes from many hospitals after hip and knee replacement. So I've used some of the data from that, some of our earlier data, to give you a glimpse of what the patient-reported outcomes are. So this one's looking at Oxford knee scores. Now, don't worry too much about the scale. For this purpose, we've divided the Oxford knee scores pre-operatively and post-operatively into poor, fair, good and excellent. So you really want your patients to be good or excellent. So this shows you that before their knee replacement, 96% of patients had very bad scores. That's fine, that means they needed the operation. Post-operatively, you see that 78% of patients had very good scores. And that's an interesting number, that 78, 80%. It's a commonly quoted number and it's a commonly found number when we're looking at the results of knee replacement. We often find that about 78%, 80%, 82% of patients are satisfied with the outcome of their surgery. And the interesting thing about that is that it's not as high as hip replacement. When we do similar scores for hip replacement, it's often 90 to 95%. So there is this generally well-known phenomena that knee replacements do not get as good results as hip replacements. That doesn't mean that the results aren't good. 80% of people with excellent results is a good result. It just means that they're not quite as good as hip replacements, which have excellent results. So that's the Oxford knee score. Now, if you look at the quality of life, and this is one of our quality of life scores that we use, the EuroQual, and it's got different domains: their mobility, their personal care, usual activities, pain or discomfort, anxiety or depression. And if you look at patients pre-operatively, nearly all of them have some problems in these areas. When you look at the post-operative scores, you see it's flipped, and many patients now have no problems at all in those areas. The other way we measure the quality of life is in a scale. It's a simple scale, just 0 to 100, where 0 is death or very poor quality of life, and 100 is perfect health. And if you ask patients to rate their quality of life prior to the knee replacement, they'll say it's around about 66 out of 100 on average. And if you ask their quality of life 6 months after a knee replacement, it's roughly about 75. And so that's nearly a 10-point gain in the VAS score. And for those used to this survey, that's a very large gain. So the increase in quality of life that is gained from having a knee replacement is very large, and compared to other procedures, that's very high. There is a question that just popped up looking at asking about the variation in pain experienced in the first 6 weeks. It's a good question. This is a painful procedure, and again, arguably more painful than a hip replacement. The recovery period is longer, and patients do complain of significant pain afterwards. There's variation personally in patients. Some patients just don't seem to complain of much pain afterwards, and some people have terrible problems with pain. It's difficult to predict. Certainly there's a lot of work being done in pain protocols where now patients have local anesthetic in large doses infiltrated into the knee. They can have epidurals afterwards. There's lots of different protocols looking at helping that early post-op pain period. That's why we give them at least 6 months to really settle down. And satisfaction, so this is looking at how satisfied they are with the result, and you can see that after the result most patients are getting that excellent to very good. Certainly not all, and there's always this handful of patients who aren't doing very well. And this question, I think, is possibly the most important. We ask patients, how do you rate your knee now compared to what it was like before the operation? And this is interesting because we want to see how many people are much better. I think to have a knee replacement, being a little better isn't enough. Being a little better doesn't justify such a massive operation. And if you look at the proportion of people that are much better 6 months after knee replacement, again, you get 78%. So what are the activity limitations? This is a question that often pops up, is what can I do after knee replacement? And it's an interesting question because when we survey patients, which is what we do prior to the knee replacement, there is a phenomenon in Australia whereby Australian patients tend to overestimate their expectations. They tend to believe, most patients will believe that they will have no pain and no restrictions in activity whatsoever after knee replacement. And I think this is a problem because we've increased the patient's expectations and they don't reach those expectations, they are unmet. There is a problem with satisfaction afterwards. And when you compare it to other countries, patients are a little more realistic. So we've been on a little bit of a campaign trying to educate patients and educate surgeons a little bit more about having realistic expectations, because they can't squat, they can't do very active activities like contact sports. They can, however, play sedentary sports, and if you count golf as a sedentary sport, they can certainly play golf. They can play tennis to some degree, and we normally recommend they play doubles tennis, for example, so they're not sprinting too much. But they can, and they can do bushwalking activities as well. So the activity level, and remembering most of your patients are over 65, the activity level is pretty good, but it's often the kneeling and the squatting which restricts certain activities. Now, other questions that I often get is, when do you make the decision to operate? This is a very difficult one. There's been some research looking at this where we've looked at patients who've had surgery and tried to dictate what is it that's made them tip them over to having surgery. And interestingly, one of the biggest predictors of a patient getting a knee replacement is the severity of arthritis on their x-rays. So you can predict who's going to get a knee replacement based on how bad their x-rays are, which is arguably quite reasonable. But what we use as a gauge is how well the patients are coping. So it's not just the signs, it's not just how much movement they have in the knee or what their x-rays look like. That's part of the picture, but it's really their symptoms. And I've had many patients who've come to see me with osteoarthritis and they're worried and they think they need a knee replacement. But when I talk to them, they're still walking the dog every day, they're walking unaided, they're walking reasonable distances, they're only taking mild analgesics, they're sleeping well at night. So that kind of patient probably doesn't necessarily need a knee replacement. One question they often ask is, well, should I have it now just in case, or should I have it before it gets bad? And that's incorrect. You can do a knee replacement at any stage. There's no need to do a knee replacement beforehand. And so we largely say to the patient, when you can't cope anymore, when it's interfering with your quality of life, with your ability to enjoy your day-to-day activities, that's the time to have a knee replacement. Now, picking the right patient is difficult, and we do tend to rely a lot on the x-ray, but there's more than that. We need to look at the patient's psychological profile, their pain profile, as well as their arthritis profile. We published a study recently, this study here, where one of our PhD students, who's an orthopaedic surgeon, looked at psychological factors predicting poor outcome. And possibly one of the biggest predictors of outcome after a knee replacement is psychological factors. So patients with depression and anxiety, patients who are on opioid medications, patients with pain catastrophizing, where they tend to perceive their pain as being more harmful than it is, patients who are worried more about their pain, and patients who have sort of centralized or generalized pain tend to do a lot worse than the patient who has specific pain on weight bearing over their medial compartment. So there are some clues as to the kind of patients we should be looking out for. Obesity, so a couple of things about obesity. obesity does increase your complication rate after a knee replacement. It increases it by 50 to 100%. Now, having said that, the risk of infection is only about 1%, so it increases it to about 1.5 to 2%, and it does increase some wound healing complications as well. So there is a slight increase in complications in obese patients. However, obese patients still benefit just as much as non-obese patients from knee replacement. So obesity itself is not a contraindication to having a knee replacement. A patient who is obese and has severe osteoarthritis will benefit greatly from that surgery. They just run an increased risk of infections like they do with many other procedures. Age is not a real limitation, and it's very common to do knee replacements in patients in their 80s, and really it's their physiological age or their comorbidities. But if the patient's arthritis is severe enough, we will consider it, and we'll often get a preoperative consultation. So, to summarize in my last slide, and I'm bang on time, interventions for knee osteoarthritis. I do not recommend injection therapies for osteoarthritis. I do not recommend any form of arthroscopic surgery for osteoarthritis. And I do not recommend, and nobody recommends, arthrodesis for osteoarthritis. There is a place for osteotomy in the well-chosen patient, and this patient is often younger, they have a good range of motion, and their osteoarthritis is confined to one particular compartment. That's the most suitable patient for an osteotomy, but that only adds up to a few hundred a year. It's knee replacement, which is done in 50,000 patients a year in Australia. It's an effective operation for severe osteoarthritis. It doesn't give 100% results, but patients just need to be aware of that. I think patients just need to be informed of the relative risks and benefits, and they need to be involved in the decision making. So I'll conclude the lecture part of it there and throw it back to Genevieve.
Thanks very much, Ian, for a most interesting and comprehensive presentation. If anyone has any further questions, please type them in the message box now, because we've got about sort of 8 minutes till we finish this evening's presentation. There was a question that came through, Ian. Is there evidence that exercise prior to knee replacements helps improve outcomes?
Yeah, there is some evidence for that, and so most, well, I don't know if it's most, but a lot of centres now will give patients an exercise program prior to their knee replacement, and many of them will see a physio leading up to the knee replacement. And the minimum that provides is at least it gives them a good idea of what they're in for afterwards, and they can practice some of the exercise. It gives them a good idea of what they're in for afterwards, and they can practice some of the exercises that they're going to do afterwards as well. But certainly a lot of the focus these days is on maintaining activity. We don't immobilise patients at all after knee replacement surgery. We exercise them as much as we can before, as much as we can afterwards. Yeah.
And what about stem cell therapy?
Yeah, I kind of glossed over that. I did mention that in one of the earlier slides as injection therapy. So I count platelet-rich plasma, hyaluronic acid, stem cell therapy, and corticosteroids as injection therapies. There's no place for injection therapies. All of the studies that have been done, the systematic reviews that have been done, have not shown a clinically important or lasting improvement in osteoarthritis from any form of injection. It's a great statement to make because I don't have to sort of tease it all apart. Injection therapies do not work. There was a study done in Sydney where they compared stem cell injections for osteoarthritis to sham injections. They found exactly the same response in both groups. It is no better than placebo, and it is literally a waste of $10,000.
And I think you covered this one, but what about evidence dealing with psychological factors such as anxiety pre-op? You did mention different levels of people with have anxiety and depression and so on. It's
a negative predictor for outcome. So if you have patients who are pain catastrophizers or have anxiety and depression, they will have a worse outcome after knee replacement. The question is, though, is some form of intervention to address that preoperatively going to improve those outcomes? And that hasn't clearly been shown yet, although there are some ongoing studies in that regard.
And with regards to different, I suppose, surgical approaches and also patient-reported outcomes for quality of life and pain, has there been much published literature around those aspects?
Looking at surgical techniques.
Different techniques you mentioned,
yeah.
and then the outcomes such as pain and quality of life.
Yeah, so different techniques, there's a couple of things we can look at. So there's partial knee replacements versus total knee replacements, and the results of a total knee replacement are certainly more reliable and better. There are some patients who may be suitable for a partial knee replacement, but as you can see, over 95% of all knee replacements done in Australia now are total knee replacements, or about 95%. As far as other techniques, so in the hip, for instance, we know that there's different ways you can do the hip replacement now. There's different approaches you can use. In the knee, there's a little bit of that where you can approach the knee slightly different ways, but by and large, knee replacements are fairly standardized, and there isn't a huge difference in surgical techniques. There's not even a huge difference between different types of knee replacements, because there's different sort of, the mechanics of knee replacements vary slightly between brands, but the difference you're looking at in the outcome is very marginal, and I tend not to put much importance on that.
And Ian, question, why do you think that patellofemoral replacement outcomes are relatively poor?
There's a few reasons. They tend to fail for several reasons. So they fail mechanically. They can come loose, and they can cause pain, and they can wear unevenly, and so they just tend not to work very well mechanically. And also, I think some patients, because they're prone to get osteoarthritis, they will get osteoarthritis in the other compartments as well. And this is one of the reasons of failure of partial knee replacements, is that the partial knee replacement may itself survive, but they will get osteoarthritis in the other compartments.
And an interesting question, are 3D printer parts being used to create exact replacement parts these days?
No, they're not. No. No, there are some high-tech things being done in knee replacements, and certainly we're using 3D modelling from CT and MRI to develop guides as to how to cut the knee perfectly. But the replacement parts that we use are highly matching and highly engineered so that they do not wear as much. And with the use of special materials that we use these days, such as highly cross-linked polyethylene, the plastic we use is much better than the plastic we used to use. And to some extent in the knee replacements, and certainly in hip replacements, this has been shown to make a big difference to the longevity. And so the wear rates of knee replacements is nothing compared to what it used to be. When I was a junior doctor, we would often see patients come back after 5 or 10 years with plastic liner completely worn out. They'd have to have the plastic liner replaced. And these days that's much less common. So there's probably no need for that at the moment.
And one last question from me, to what extent do you think sort of previous information provided by other primary health professionals would influence patients' expectations around knee replacement and even the post-operative outcomes and so on?
Yeah, I think it'll help. My aim in addressing some of the problems with increased expectations is to address it at all levels. So I think patients and the public should be informed in general. I think that the referring primary care provider should also be aware of this and say to patients, warn them that this is firstly a big operation. It's an effective operation in many patients, but not all patients. And some patients do have ongoing problems. They have ongoing stiffness, they have ongoing pain after a knee replacement, and they just need to be warned that that's a possibility. And they also need to be warned of the other thing that I mentioned, which is the activity limitation. There's certainly some things that they won't be able to do, like squatting and sometimes kneeling. As well, and they won't be able to play vigorous sports. So I think, they need to be just cautioned a little and just made a little bit more realistic about what the outcomes of knee replacement are and where that comes from. It should come from the orthopaedic surgeon, it should come from the primary care provider, and it should come from the general knowledge that people see on the internet as well.
I think that finishes our questions for this evening, Ian. So I'd like to thank you again for a really fantastic presentation. Thanks so much. I'd also like to thank everybody for